Hello, everybody. Welcome to Dose of Inspirational Life. Today's episode is part two of the Cancer Institute and Community Migrant Resource Centre's initiative podcast on cancer prevention. I'm your host, Shika. Our distinguished guest today is Christopher Horn from the Cancer Institute, New South Wales. He's an expert in bowel cancer. In this podcast, we will start with the basic understanding of the bowel itself, its location in the body, and the vital role it plays. After that, we'll navigate through the various aspects of bowel cancer, from lifestyle factors contributing to the risk of bowel cancer to preventative measures. So without further ado, you already see Chris, who's just come into Dose of Inspirational Light. Welcome, Chris.
Good afternoon, Shiga. Thank you for inviting me along.
Thank you so much for
Very happy to be
accepting
here.
the invitation. Yes. How are you?
I'm well, thank you. Quite a warm day, but I'm inside, thankfully, in the air conditioning.
Yeah, nice. Okay, so Chris, let's start with some basic questions on firstly who you are. Who is Chris? And if you could tell us a little bit about you for the purposes of the audience.
Sure. So my name's Christopher Horn. So I have a bit of a varied background. I think I can touch on a little bit of that. I work both in my professional role at the Cancer Institute, where I head up the bowel cancer screening program. But it's been a bit of a long road actually to that point. I started as a radiation therapist, and I did my training at Newcastle Uni and then interned out at Westmead Hospital. So I worked there for a few years and specialised in paediatric cancer. So I worked with kids and I worked with general radiation therapy as well. Um, and then decided I'd move overseas and see what it was like in the UK. So I worked for the National Health Service, the NHS, in the UK for a little while as well, and then came back home and worked for Peter MacCallum in Melbourne and a couple of other hospitals. So I've kind of got a bit of a flavour of radiation therapy and cancer treatment in a lot of different places and a few different countries.
Yes.
Um, yeah, I outside of outside of work, I also work with the College of Health Service Management as well. So I do a lot of work with the development of other health managers and health leaders in the field and trying to, I guess, improve health outcomes for the community generally in a much bigger sense than just cancer as well.
Wow, that's quite a resume right there. Any reason why you wanted to go into health, specifically with all this health, even in your spare time you do something related to the health industry?
Yeah, it's interesting because when I was a kid, I never talked about this, and this is not something that I ever really thought I would do. I didn't do these sorts of subjects at school. I did engineering at university to start with, and I just didn't want to do that. And I was trying to find and work out what I did want to do. And
Yes.
somebody who worked for me for a little while did radiation therapy at uni, and it sounded like this perfect combination of technical physics, chemistry, that kind of thing, and science, but also working with people every day. And I thought that sounds like that's for me. So I went back to uni and I did radiation therapy. And I think from the first time I did a placement in a hospital and only got to walk around behind other radiation therapists and look at what they were doing, but I knew that was the field I wanted to work in. And I think I just fell in love with it. And I really miss working with patients now, actually. I love the day-to-day work of engaging with people. I think radiation therapy is a really important job. We tend to get to know our patients every day for a long time, for 5 or 6 weeks, and that's a really important relationship, I think, to have with a patient, to be able to kind of connect and help support them through their along their cancer journey.
Yeah.
And yeah, it kind of I think it morphed from there into me deciding that I wanted to take what I knew and what I'd learned and try and just improve things generally, which meant, working at a different level to being face to face with patients. And that's just kind of continued. I've gone from clinical work into hospital management, where I did care redesign or trying to change the way we care for people and the care that we deliver to make that higher quality and safer and better for patients. And then I moved back into the cancer space. And here I am in public health, where the encourage people to stay well and do what we can at the, I guess, at the front end there, and really try and avoid cancer at all if we can, or at least pick it up early. So yeah, I think it's just been a continual drive to work in the cancer space and find another way to work to make even more impact.
That's amazing. So Chris, that's quite an interesting story, but I know radiation therapy is something you fell in love with, and it is quite a hard role because people are going through quite a lot. So what motivated you to continue down this path when you've got, all of your patients that are actually going through very hard times?
Yeah, that's a good question. It's an unusual place, somewhere that does cancer treatment. A lot of people, they don't have any exposure to it until they're there with a family member or a loved one, or there for themselves. They just have no awareness of it all, I guess, and they have certain ideas about what that would be like. I think for me, really early on, I just got this real sense that I was engaging with people on what is probably the worst day of their life, or one of the worst days of their life, and that if I could make that easier for them, that was a really important job. That if I could help ease them into that and help care for them along, was, radiation therapy and things like that can be quite challenging. There was just really important to be there and to be a person. If you're good at that, and I felt like I was good at that. So yeah, I got a lot of fulfillment from my job.
Mm. Now that is quite heartwarming. And, for me, I also lost my dad last year to cancer. And,
Sorry to hear that.
yeah, and it's been a tough thing for me. And, and I understand the grief that's involved, especially when you hear the news. And
Yeah,
so it's good that there are people on the other side like you who are there to care and provide support. Can we just start with the basics? What's cancer, Chris?
sure. So cancer is it's a really, I guess, a general kind of description that tracks for a few different types of cancer. Is really that it's an abnormal cell growth. So if we think about something like a tumor, that might be caused because the DNA in our cells, which tells our cells how to grow, what to do, how to divide, and really importantly, when to die, so that new cells can take over. Sometimes, if the cell clock is a bit damaged or the DNA is a bit damaged, we get growth that's out of control. It's not happening as it's supposed to do, as it's supposed to happen. So we can end up with an excess amount of growth and those cells aren't behaving properly, and we can end up with a tumor. Cancer is a malignant tumor, so it's a tumor that's going to keep growing and keep invading and cause other, serious health effects. Yeah, I guess that's a bit that's a simplified kind of overview of it, but there are obviously a lot of different cancer types that grow in not only different parts of the body, but even within one part of the body, they can be different cell types and all sorts of different properties. And we're learning a lot more about that now than we used to have an idea of as well.
Mm, yeah,
Treatment is becoming a lot more effective because we know more about what it is that we're treating.
yeah. With such a diverse career that you've had, with radiation therapy and Peter MacCallum and all the various channels of work that you've gone through, why now Cancer Institute? Is that like a easy transition, or is it?
I think it was a sensible transition. It looked like a good transition at the time. But I think what really appealed to me about the Cancer Institute and this role specifically at the time that I moved into it was that the bowel cancer screening program was kind of in its infancy. It had been around for almost 10 years, started in 2006, and in 2015, it really hadn't rolled out very far. We were only screening people every 5 years between 50 and 65, and the guidelines said screen people every 2 years from 50 to 74. So we were nowhere near full rollout of the program. And I guess there wasn't a lot of attention on it. People didn't know about bowel cancer. It's the second most common cause of cancer death. But if you would go down the street and ask people about it, most people don't know. They don't know that they're at risk of it, or they have an idea of risk factors that are not quite accurate. So something really, really needed to do something about. Now, the government that was coming in at the time had made an election promise that they'd roll out the program faster if they came in, and they did. So it was due to be completely rolled out between 2015 and 2020. So all of a sudden, kind of all eyes were on bowel cancer screening. This position was created, and we needed to form a bowel cancer program team. And so I was really excited about that because I think the program is obviously really effective. It's a great public health initiative. It really genuinely saves lives and avoids cancer. And that was, I think, really obvious. And I had the opportunity to come in and take on that role and essentially build the team from the ground up,
Yes.
which was fantastic. And we took on the follow-up service 6 months after I started. So we started doing the follow-up for all the participants in New South Wales who have a positive test to help them continue on to see a GP and have their colonoscopy and navigate the system. So there was just so much opportunity to do so much. It was a really a fantastic opportunity to get on board with something really and shape it from the ground up.
Yeah.
Well, not from the ground up, but be involved in its development.
Yeah, no, that's that. I mean, it sounds like a good career fit, but it's also good that we've got you now in the Cancer Institute New South Wales, where we are rolling and talking about these kinds of things. So, okay, so just before we delve into cancer and everything else, just a little bit more about you. Outside your professional life, how do you balance your professional and personal life? With so many professional hats that you are wearing, how do you balance that personal side?
Yeah, so I've been here for 8 years, and there've been 8 very different years that I've been here and doing outside things. I used to do long course triathlon and long distance running. So
Wow, nice.
it's a 12-hour long races. So it's a lot of really lots of running in circles and swimming in straight lines and things like that. So that used to be a really good outlet outside of work. I used to play music, and I like to still if I get the chance to, with one of my really close friends. So we've played together in bands and things over the time. So that was a really good outlet as well. Now I'm a father of 2 little boys, 2 and 4, and they are curious and capable and full of life. So I'm pretty involved there. That's a lot of my time, and I'm just starting to get back a little, stick my toe back in the water, and get back into running a little bit now. I just got talked into doing the City to Surf on the weekend, so I'm
Wow.
so I'm officially running again.
That's awesome. Any significant challenges that you faced, outside life or during your work life that you like to share?
Yeah, I think there are always things going on out there, and I think working in certain jobs and other responsibilities like being a parent changes your view of things as well, and just creates different stresses that you didn't know about, and different concerns or worries or anxieties or whatever it is, provides different challenges to navigate. And I think that's just always, it's nice to have change, right? It gets consistent, it gets boring. But I think some of the biggest challenges we face at work, I think particularly in this program, are really kind of trying to prioritize the work that we do. There's just so much to do, trying to find those really important pieces of work to do and focusing on that. That's always a really big priority for us. There's an example of a project that we've done where, we recognize that we don't have the in-reach into a lot of communities, particularly multicultural communities, where we're a government organization. No one's necessarily listening out for a message that we're giving, and we might not be, getting into those populations and community groups that we need to talk to. So we've had a few initiatives. The Flipchart is one of them, and had really good reach and really good uptake and really good engagement. So trying to really build on that. I think the most rewarding thing I have is actually the team I work with. They're incredible. They show up every day. They get stuck in, and they are so committed to the people that we're trying to change outcomes for.
Yes. I've met a few of them. They are a good team.
They are.
Okay, so let's go back into the topic of today, which is bowel cancer. Again, starting with basics because people may not know.
Sure.
Where in the body is the bowel, and what does it do? What's the function of the bowel?
So the bowel is the colon and the rectum. And so we talk about colorectal cancer or bowel cancer. That's the same thing. It's just a terminology difference. And so when we talk about the bowel, we're really talking about the large intestine and the rectum. It's the lower part of our digestive system. So really, it's the part between the stomach and the anus, or where the bowel opens. And it's all of the food that we eat goes through the stomach. The nutrients get picked up, some of them in the small bowel and the small intestine, and then a lot of them get picked up in the large bowel and the colon. And so that's where, if you're going to have a problem with your intestines, it's probably going to be in the bowel, in the large intestine. That's where a lot of the issues have. So we're talking about the colon, the back passage, so the last part of the colon, which is the rectum, and to some degree the anus as well, which is the opening. But just to note that I guess we don't really consider anal cancer part of bowel cancer, and the screening test doesn't screen for anal cancer. That's something your doctor needs to check differently. But yeah, so the colon and the rectum, that's what we're talking about. And it's really just used in digestion.
Yeah. So as far as I remember from my Science 101, your large intestine is what carries water and salt, and your small intestine is what carries food. Is that correct?
Yeah, that's what they absorb generally. Yeah, so the
Absorb,
small
yeah.
intestine is doing a lot of nutrient absorption, and the bowel is absorbing a lot of water.
Okay. Is food related? Because you mentioned anything from the stomach downwards, um,
Yep.
could be. Is it related through to the food that bowel cancer could be one of the causes, or we don't know?
Yeah.
Yeah.
Yeah. There's definitely in terms of eating a healthy diet. So
Yeah.
eating a broad range of food and healthy foods, and trying to avoid too much in the way of unhealthy fats and things like that. But fiber is a really big factor. So you really want a diet that is high in fiber, and that's good for multiple reasons. One of them being that it actually helps everything bulk up and keep moving,
Yes.
so it moves through your bowel quicker. I mean, your bowel's full of waste, right? You want to get rid of it. You don't want it sitting around in there. The longer it sits around, the longer you've got garbage waste sitting in there that your body doesn't want. So that's never a good thing. You want a diet that's varied, healthy, and really high in fiber.
Yeah. You mentioned it's number two in Australia, bowel cancer. What's number one?
Number one, I believe, is lung
Lung.
cancer. Yeah, partly. The lung cancer is not particularly treatable, and I guess I contrast that. Like it is, but we still see a high rate of mortality from it, a high rate of cancer deaths from lung cancer. I think bowel cancer is the second highest cancer killer, but one of the critical distinctions, which we might get into a little bit later, is the difference between picking it up early or picking it up late. That's a really fundamental difference, and something which is one of the reasons the bowel cancer screening program is so amazing.
And it impacts, I presume, every nationality. It's not like one nationality specific that.
No, it's not. It does impact people disproportionately in different countries. But one of the things we see is that it affect Australians more than a lot of other countries. But often, if somebody comes to Australia from another country that has a lower risk, they kind of normalize to about the risk level of the country they've moved to. And we think that's to do with lifestyle factors, just the general factors associated with their daily, meal habits and lifestyle and things. So it's a little bit higher in Australia than a lot of other places.
Is it
And
because it's something that we're not doing that the other countries are doing that it's higher in Australia?
yeah, I think I do um, recall it's got a bit to do with lifestyle, so diet and exercise factors and things like that as well. Diet is a big factor for bowel, and I mean things like smoking. We have lower smoking rates than a lot of other countries, I think, but that's something that affects a lot of cancers. A lot of these risk factors are really kind of intertwined.
Okay. All right, let's delve into that as well. So, in terms of the overview of the significance of bowel cancer, you mentioned it's number two. Is there anything else that you'd like to mention in terms of the impact on public health?
Yeah. So, I mean, bowel cancer is not insignificant. We're talking about almost 6,000 cases diagnosed in New South Wales every year, and almost 1,800 people will die of bowel cancer each year in New South Wales. So that's about 35 people a week, that's significant numbers of
Yeah, it's
people.
just New South Wales. It's pretty
It
significant.
is, yeah. And cancer it's a significant disease. It's becoming one of the most significant chronic and complex diseases that we have, non-communicable disease. A bowel cancer diagnosis, or a cancer diagnosis at all, I think has a huge impact on the person who's diagnosed, but also has an impact on their family, on their carers, on the people whose lives are around them. They might be facing the prospect of surgery and radiation and chemotherapy and any combination of those, which can be, it could be a long road, and those things take their toll. In terms of what people's plans might be for their life, that might have an effect on them as well as an effect on the rest of the family. So it's not an insignificant thing, and I think if you can avoid a cancer diagnosis at all by making healthy choices, by looking after yourself, by eating well, by doing your cancer screening tests when they're offered, or when you're invited to do those when you're at the right age, those things can play a really big role in staying cancer free and minimizing that impact.
Yeah, sure. So let's talk about this early detection, particularly important for bowel cancer, and how does it impact treatment outcomes?
So bowel cancer typically grows quite slowly, but it also doesn't tend to have specific symptoms until it's quite well developed. So not all, we have growths in the bowel sometimes called polyps, and these are those where I was saying you can get growth because the cells aren't doing what they're supposed to do. They're growing and they're continuing to multiply when actually they shouldn't. So one of the things you can get is a polyp, and that's a small growth in the wall of the bowel, in the lining of the bowel. Not all polyps will turn into cancer, but one of the things we know is that almost all cancers start as a polyp. So bowel cancer can grow quite slowly there in the bowel, and you might have no specific symptoms at all until it gets quite developed, and you might then have, visible bleeding or blockage of the bowel or something. At which stage it's really quite developed. It's a late stage cancer. The difference we see between stage A, which is the earliest, the lowest stage of cancer, versus stage D, which is the most developed, is that at the earliest stage, your chance of success, of treatment success, is 99% in 5 years' time. If it's the later stage, it's about 14%. So if you were to get a bowel cancer diagnosis, and the odds you've got there are 99 in 100 versus 14 in 100, that's a vast difference.
Yes.
And the key here is screening. As soon as those polyps start growing, something we know about polyps is that they tend to secrete small amounts of blood into the bowel, microscopic amounts of blood. So before you can see it with your eyes, it will be in there, and that's what the test is looking for. The test doesn't actually look for cancer. The test looks for microscopic amount of blood in the poo. And so if it picks that up, what that says is you need to go and have a colonoscopy and find out what the cause of the bleeding is. And in theory, you get it at an earlier stage, where if you'd waited till you had symptoms that were significant, then you might have picked it up at a much later stage. So it's the only way to look for early stage bowel cancer. And yeah, very important that you do so. It's a lot of thoughts people have are around not wanting to know or ignoring it till if I have to, I'll go and get checked, or I'd rather not know. But
yes.
that's really the opposite. You do want to know. You do want to go looking. You do want to find it now. Find it today, and hopefully get it when it's early. Or one of the great things about this is actually that because you can pick up those polyps, you might pick up something that's going to become cancerous later that hasn't become cancerous. So you may never get a diagnosis because you do the test, you find that microscopic blood, you do a colonoscopy, the doctor says, we found some polyps, we took them out, you're good to go.
Yeah.
See you in a few years.
Yeah. So this microscopic blood is not seen in the naked eye, but it can be seen in the test at a lab. So that's why it's important to do this test, which we'll talk about.
Seeing blood in the bowl or seeing blood on your underpants is a symptom, can be a symptom of bowel cancer. And again, this is the thing, it could be a symptom of other things. It could be a symptom of hemorrhoids. If you see that symptom, you need to talk to your doctor about that. The test is no longer the right thing to do there. You have an obvious symptom that needs to be investigated. The test is for people who are, again, often people will say, but I feel fine. I have no symptoms. I don't need to do the screening test. Again, in fact, it's the opposite. If the test is designed for people who feel well, who don't have symptoms, this is how you check that everything is in order. And if it's not, you catch it before it, ideally you catch it before it develops into something bad.
Yeah. So generally, from what I've also read and what you just said, bowel cancer at the early stages has no symptoms. So it's important for that testing to happen.
If it does, they're quite often they can be quite vague symptoms. They're non-specific. You wouldn't say to somebody, I have some unexplained weight loss and my tummy's a bit upset. That doesn't, point you towards that's not going to trigger thoughts about maybe I have bowel cancer. They might be the only symptoms that really present in that early stage.
Yes.
And, in a few years' time, it could develop into something that you end up, needing to go and see about because you've got a blocked bowel. And if it's been left that long, that's a very different position to if you picked it up earlier by having done a screening test.
Yeah. Okay. Could you explain the key components of the National Bowel Cancer Screening Program?
Just to know that the screening program is an Australian government initiative. So the Commonwealth government engage Telstra Health to run the cancer screening register, and they engage Sonic Pathology to send the tests out.
Yeah.
So that pathology provider sends a pre-invitation letter to everybody aged
Yeah.
between 50 and 74 every 2 years.
Yeah.
And it says that you've got a screening test coming and that it's really important that you do it.
Yeah.
And then you get the kit in the mail. You do the test kit, you pop it back in their reply paid envelope and send it off, and you'll get your results. And then the next step after, if you get a positive test, the next step is to go and talk to your doctor about having a colonoscopy, which is, I'm happy to explain a colonoscopy. That might be helpful.
Yeah.
So a colonoscopy is a medical procedure that's done typically in a hospital, but can be in another facility as well. It's done under a light anesthesia, so just to keep you comfortable.
Yeah.
You need to do a few days of preparation, so it's a special diet to make sure your bowels are as cleaned out as possible. And then the procedure itself is a thin tube, so quite a thin tube with a camera in the end of it, being inserted into the rectum to have a look basically at the inside of the colon and the inside of the rectum and check to see what's happening in there, like what the cause of the blood might have been, but also just to make sure that everything is healthy and operating properly. And then the doctor will talk to you about the result.
Okay. So that's the end process. So let's talk about the starting process. When people do get that letter and then they do get this test, people don't know what's involved. What does this envelope firstly look like? I'll put an image on the screen.
Yeah, so the envelope is a little A5. It doesn't look like what it's going to be, I think. I suspect a lot of people get it and they just don't, they're not expecting it.
Yes.
They don't know what to do with it.
Yeah, exactly. And the reason I mentioned that, and to be fully transparent, we got one of those and it got thrown in the bin. So, here I'm talking about it because it is critical. Do not throw it in the bin and just have a look at the picture that's going to be on your screen. This is what it looks like. And it is really important. And as Chris mentioned, it can save life. The chances of survival are much higher if you do the test than if you don't do it. Okay, so Chris, let's talk about the process of bowel screening and what exactly will you be getting in the mail?
Sure. Okay. So when you open that package, that magical package that arrives for your 50th birthday or every 2 years after that, after you've done your last test.
So it comes at 50, is that right?
No, comes at 50.
Earlier than 50. So we expect
No, that's an interesting point. We'll just do a sidebar here. The guidelines, the National Health and Medical Research Council guidelines for colorectal cancer screening have just been updated. So there will actually be a change to the starting age for screening. At the moment, it's everyone from 50 to 74, but soon, and I'm not sure when it will happen because the report needs to be accepted and the findings applied, but we will soon see a change and the age range will be 45 to 74.
Oh, okay. Wow.
So making it 5 years earlier for the entry age into screening.
Okay.
Is
there a reason why that entry range has changed?
We are starting to see over time that the incidence of younger onset bowel cancer is increasing very slowly. And so last time the guidelines were updated was 2017. And at the time they had a look at the starting age for screening and looked for the evidence to decide whether or not it should stay at 50 or move. And the evidence was not quite borderline, but wasn't strong enough to support that. But in the 5 years since, it has actually demonstrated that we should be screening a little bit earlier as well. So we see currently about 90% of bowel cancers, or 91% of bowel cancers are diagnosed in people over the age of 50.
Yeah.
But that age range is just shifting slightly. We're starting to see a growing, although still small, but a growing number of earlier onset cases.
That's a little bit scary when the age shifts to a younger age. So yeah, please look out for this envelope, please test it. And then Chris, let's go back to the original question. What do we expect inside this kit and what do we do about it?
You get everything you need to do the screening test, and it's quite a simple test. I just note we have about 20% of people do the test the first time. If once they've done a test, they're almost 3 times more likely to do it the next time they get it. And I think that's because there's this idea that it's going to be hard or it's going to be dirty or whatever and then once people do it, they realize actually it's quite simple. And so they're happy to do it again. So what you get in the kit is 2 toilet liners, and they're both biodegradable. You can flush them down any toilet, even septic systems. They are flushable. They will completely disintegrate. You get 2 green top collection tubes, and they have a collection stick inside that's attached to the lid. So you just need to take the lid off, and that removes the stick. And when you click it back in, you just put it back in the hole and click it shut. You have a Ziploc bag that has 2 compartments that conveniently fits the 2 little test tubes, and a reply paid envelope, which you're going to use to send the kit back. So when you get the test, go and put it somewhere that's going to be handy for next time you go to the toilet and do a bowel motion. In the bathroom is a great place to put it. You need to begin by, if you need to do, there's no way to talk about this other than to just talk about it. So if you need to do a wee, flush the toilet, then lay the liner down in the toilet so it's just sitting above the water. Do your poo, open your bowels and do your bowel motion, do your poo. And then you need to take the test tube, open it, and you'll have basically holding it, and it's a stick. You need to wave the end, just the end of the stick. Just wave the end of the stick through the poo, okay, in like an S shape, so you get a bit of a sample from across the poo. You only need something the size of a grain of rice. So this is not a big sample. We just need a tiny little rice grain size sample of poo. Once you've got that, put it back in the test tube, click the lid shut, and give it a shake. That's your first sample. That's it. Flush the toilet, go about your business. Next time you go to the bathroom to do a bowel motion again, you need to repeat the test. So this is a 2-sample test. Do your test on one day, on the first bowel motion, and then do it again for your next bowel motion.
Can it be done on the same day, Chris, if people go more than once?
No, I believe that can be done on the same day, but they don't need to be. Some people might not go for another day or 2, or
sure,
maybe 3. It's a good idea to keep the sample in the fridge. Now, I know people hear that and think no, but actually there's the Ziploc bag that I mentioned has a privacy sheath in it. So there's a grey cover, so that when you put that in there, you can't see what is in there. As I said, it's a rice grain sized piece that goes into that solution as well. It's not obvious what it is. Pop it in there. If you need to, put it in a bag or put it in a box and stick it up the back of the fridge. It's fine. It's just that it's sensitive to heat damage. So the fridge is a great place for it, just so that you don't have any heat damage. When you've done the second sample, and I did skip a step there, you do need to write your name and date of birth and details and the time and date of the sample on the test tube. When you take it, that's a good time to write that down, that when the sample was taken. When you've done both samples, you just need to pop them in the reply paid envelope with the details form that comes with your test, seal it up, go and drop it in the post box as close to pickup time as you can. 4 o'clock in the afternoon is a good time to do it, because the post is about to be collected in most places, just to minimize how long it's out of the fridge. One of the things, if people want to see a video, there's a video on dothetest.com.au, and we can also link to in-language videos that the Commonwealth have as well. And so I think one of the biggest things to recognize too is that stigma kills. Conversations can kill. If we're not talking about this, if people don't feel like they are able to ask questions and able to do it and able to talk about it, and they don't do their tests, that could be a very different outcome for that person than if they'd done the screening test. And now the biggest risk factor that people have is being over the age of 50. Unless they've got a strong family history, in which case they definitely need to talk to their doctor. For everyone else who doesn't have a strong family history, your biggest risk factor is being over the age of 50. You need to be doing the test, and we need to be, as communities, talking to each other about how important this is and how easy it is to do, and asking for help and asking for, motivation to kind of do this, and checking with each other. Did you do your test? Have you done it? You just turned 50. Happy birthday. Do your test. And encouraging each other. If we don't talk about it, we will never break that stigma down.
Yes. It's very important. Let's save our own life, because at the end, the person who's going to suffer the most is us. So if we don't take care of us, nobody else will. People can only care for us, and people can only empathize with us, but they can't go through the suffering for us. So let's avoid that suffering. Let's do that test. But why is 74 the cutoff date for the people?
People over 74 aren't invited to screen, because when we offer a population-wide screening program, we have to think about risks versus benefits. So there's benefit to finding bowel cancer, But once somebody's 74 and over, what we see is that there are more complications that come as a result of the diagnostic follow-up. So after a positive test, you'll recall I said it's normal for someone to go and have a colonoscopy. In someone over the age of 74, we tend to see a higher rate of bowel perforations, which is where the wall of the bowel can get torn because the person is older, their skin is a bit thinner. It's the same inside as it is outside. It's just a bit more prone to being torn, and that's a significant injury to have. It's rare. Colonoscopy is a generally safe procedure, but we start to see more of those in older people. And also complications because of the bowel preparation. So I mentioned the bowel preparation means changing your diet, eating certain foods, having to drink a lot of water, and then in the kind of day beforehand, there are some bowel preparation solutions that you need to drink. Now, I've done one as well. They're uncomfortable. They're not particularly pleasant, but for someone who's otherwise fit and fairly well, they're not too problematic. But again, as you get into your older years, that can cause some problems. So on balance, when they look at the evidence, they say that over 74, it's no longer a no-brainer to screen. Now, that doesn't mean that people shouldn't screen. If they want to, they should talk to their GP about it. Talk to their doctor who knows their personal circumstances. I've seen 74-year-olds who would pass for a fighting fit 60-year-old. You know, they're in great shape. They want to look after themselves. Screening might be the ideal thing for them, but for other people, it might not make sense. So after 74, definitely talk to your doctor about any symptoms, if you have them, or family history, but also talk to them about whether screening is right for you. They can recommend another test. It doesn't have to be the national program. They can give you a sample that's actually a very, very similar test, or they can refer you to a pharmacy to go and buy one. And if they write you a referral, if they say, yes, screening is a great idea, I recommend it, they can write you a referral for screening before you go and buy your test. And then you can claim back the pathology component of the test as well. So you'll be able to claim a little bit back.
Once we've sent all of this to the post office, pathology does its test, we get a letter. How soon will we get this letter?
Anywhere from a couple of days. They say within 2 weeks, but I've seen it be within, a day or two. It can be quite fast. And often if you've nominated your GP on the form and it's all set up for that GP, they can send it across electronically. So they might get it quite rapidly. Okay. And so negative means no blood was found. No, great. No, screen again in 2 years. Yeah. And the program used to invite people on their birthday every 2 years. And it continues to do that if people haven't screened. So they will get one at 50, 52, 54, 56 within a few months of their birthday. Once they've screened, they'll get their next test 2 years after their previous one.
Okay. And if it's positive, it means go to your GP and do a colonoscopy, basically.
Yeah, go to the GP to discuss what's right. Again, what's right for you. For most people, colonoscopy will be the next step. That's typical. But you might not be able to have a colonoscopy for some reason. So, talk to your GP about that. They will refer you to one of 3 different places. Yeah. They might refer you to private rooms. So that means you're seeing a private specialist in their own rooms, and that will cost you, you'll probably get an appointment quite quickly, but you'll typically pay money out of pocket to go and see them. Okay. The other option is if there is a public outpatient clinic available at your local hospital, they might have a clinic you can go to. Yep. Now that will be free, but you might need to wait longer to be seen because that clinic will have a wait list. There's a third option, and this is something that we've been supporting rolling out across New South Wales, which is called direct access. This is an outpatient clinic, but it's specifically for people who have a positive bowel cancer screening test, who need a colonoscopy. And it's a telephone-led triage, so it's much quicker. The referral goes straight to a specially trained nurse, and instead of you needing to wait to be seen in the clinic, that nurse can call you quite quickly and go through all the questions they need to on the phone. And what they're trying to work out is, are you pretty much otherwise fit and well? Because if you have a positive bowel screening test and you're fit and well, you don't really need to be seen. We can just book you in for your colonoscopy. So you just go straight to colonoscopy booking. Then you can skip that whole wait for the outpatient clinic, and it still doesn't cost you money, nothing out of your own pocket, because it's still an outpatient clinic. So that's available there are clinics available in most of New South Wales now. So that's a good conversation to have with your GP, is what's right for you. Do you want to be referred to a private specialist, to an outpatient clinic, or if there is one available, a direct access colonoscopy clinic?
Okay.
We'll have the website's not live yet, but we will soon have information up live on our site about where they are. But we should be able to share some information with you and your viewers as well about where people might find those clinics. But they're pretty well populated, particularly around Western Sydney. We've got them at Westmead, Westmead, Blacktown, St George, St Vincent's, Sutherland. There's one at Illawarra now. We've got them in regional areas as well, in Orange and Dubbo and Broken Hill. There are a lot of them around the place now. So great option, but the GP may not be aware of it. It's a good thing to be proactive with and have a discussion with your GP about what's right for you. And so they'll refer you on. And then again, so it's that consultation about whether or not colonoscopy is right. And then you get booked for your colonoscopy and go and have that in the hospital.
Yeah. Okay. Sounds good. Is colonoscopy synonymous with the term endoscopy? Or are they two
Yes.
different things? Yeah, it's not.
Similar. Endoscopy covers a bunch of procedures, a range of procedures. Colonoscopy is one of them. So colonoscopy is specifically scoping or looking at the colon.
Yeah.
Endoscopy is looking at the inside of you. So there are other types. There's a gastroscopy, which is the camera goes into the mouth and looks down from that way. So different types of endoscopy, but colonoscopy fits within the term endoscopy.
Given the importance of early detection, how is the program that you guys are running working to raise public awareness beyond us talking about it today?
That's a good question. So I mentioned what the Australian government do in terms of sending the kits out and engaging the register and the pathology provider. We do everything else basically within the states and territories. So the program team I lead is 19 people, plus another sort of 2 or 3 that work on campaigns specifically. We do a range of things. So we do social marketing campaigns. We run big television advertising marketing campaigns. We've done a few of those in 2018, 19 and 20. I think we did one in 21 as well. We haven't done one for a couple of years, but hopefully we'll have another one in a couple of years' time. The Australian government will actually run one this year.
Okay.
This
year being 2024?
Yes, I think they're doing another one this year as well, or they've contracted somebody to do it. So there will be advertising in the field, I anticipate, but we won't be doing the campaign ourselves this year. But we do a huge social media presence as well. So we have advertising we run on Facebook. Some of that is or used to be birthday targeted as well. So we could kind of identify the cohort of people who are in the screening age range and really get ads in front of them about how important screening is and content. We do a lot of engagement with organisations such as yourselves. We run a series of community grants to encourage, education into communities, in particular, as I mentioned earlier, multicultural communities where we may not actually have the straight line communication in there, but by engaging with trusted community providers and organisers who know their community and have a line of conversation in there, we can support that messaging to get it in there. The Flipchart I mentioned before is one of those. We use that with the grants to get people educated about how important screening is. Bilingual community educators, Aboriginal health units, lots of different avenues like that. I guess the 3 messages we really are trying to get at is that bowel cancer is serious, that bowel cancer is something you can do something about, and that there is a community of people around and services that are available to support you in doing that. So, take control of your health.
Chris, how does Cancer Institute actually know that people have turned 50?
Yes, well, that is done based on the Medicare register. So people who are in the correct age group and have a Medicare eligibility or have a DVA, a Department of Veterans Affairs card, are eligible to do bowel cancer screening. And so the way that operates is that the Medicare register sends to the National Cancer Screening Register the list of people who are eligible and due to be invited, and then that's how they generate the invitation. So important to make sure that your Medicare address is up to date. If you move, make sure that's updated so that they have your correct address details.
Yes. And you mentioned about a flip chart. So is flip chart just the way it sounds like? It's like a flip chart where people are going through a little bit of information on what bowel cancer is.
Yeah, that's essentially what it is. So in late 2018, we launched what we call the Bowel Health and Screening Flipchart and Facilitator Manual. So these resources were co-designed with local community, multicultural health and community organisations. So we did this in a 3-phase approach. And the first phase was just to engage community members and have them to come together with us and talk about the key messages that we need to communicate and how would be best to do that. What will resonate? What's important in that community? How should we present the information? So we built the Flipchart that allows somebody who's received a level of training to be able to go out and talk about bowel cancer screening with the community or with patients. In the years that followed after that Flipchart launch, we have educated more than 220 bilingual community educators and health or community workers from more than 30 different organisations who've been trained in their use as well. We've issued 22 grants to support education using the Flipchart, and we've had almost 4,000 people from multicultural backgrounds and over 20 language and cultural groups come and attend a session where somebody has, done a stakeholder-led community education event. So somebody that we've trained in the Flipchart and maybe given a grant to has held events that those community members, nearly 4,000 people, have come to.
Okay. So somebody listening today has got parents who
Yep.
are not fluent in English. What other languages can they get this material in?
Yeah, so this is there's a really broad answer to this question. The Flipchart, I think, is translated into about 14 languages now. Korean, Syrian, there's a lot. But then we also have things like how to do the test videos, which then have translations. We have the National Bowel Cancer Screening Program, the Australian Government resources, which have been translated as well. So there's quite a lot on offer. I think it might be best if we link some of that in for you. Happy to share those. And I think based on the language that somebody speaks, they should be able to find some of the things they want, but they just might be different, located in different places.
Yeah. And also, if you are a migrant who has arrived in the country less than 7 years, Community Migrant Resource Centre, I volunteer for them. If you go and speak to them, they will be able to also guide you in the language that you speak as well. And Chris, the exciting thing is the other day after I started doing this campaign, I was, flicking channels on the radio and I heard a campaign on bowel cancer, which was really exciting, to talk about, to listen to it. So it's working. So there is awareness happening.
Guessing that might be the national campaign that's out at the moment. And I have heard they've done some radio spots as well. I've caught a couple on the news as well. Yeah, really important that message is getting out.
Yes. Yeah, and we need to keep spreading that message, especially if there is a prevention available. So Chris, how can individuals stay engaged in the screening process over long term, and what resources or support systems are available for them?
That's a good question. Screening is it's such a proactive way to stay healthy, eating well, being active, talking to your doctor about symptoms if you've got them, but really proactively screening and trying to maintain your health. So for women, screening starts at about 25 with cervical screening. Then we offer breast screening from 50 or from 40, I think, and invited from 50 to 74. And obviously bowel cancer screening starts at 50, but will soon be 45. So really being on top of those tests and doing them regularly. It's not just that you screen for cancer once and then you're fine. You've got a stamp of okay and don't need to worry about it again. It really is important that you screen every 2 years if that's the proper interval. And that's because bowel cancer can develop at different times. So staying on top of those screening messages, connecting in with your community health organisations as well as your doctor, having upfront good conversations regularly with your doctor, but connecting with organisations such as yourself who offer really quite tailored advice and ability to connect people into resources, and organisations like the Cancer Institute who really value those partnerships and that ability to reach audiences that way.
Yeah, perfect. So what are some of the common barriers or misconceptions that people may have about participating in bowel screening, and how can we address those? Cover some of them.
Yeah, we've touched on the ick factor and the bowel cancer is not we used to say bowel cancer kills conversation. It doesn't have to kill you. It's a good one to bear in mind. We've covered a few there as well about not wanting to look for something you don't want to find. Yes. But these things can be very specific to different cultural groups, people with different backgrounds and different language groups and things. They're very particular in the way that they arise. That this is a good news message. we can find this early, so we should look for it.
Any other messages or information that you would like to share with our listeners to emphasize, again, the importance, or anything else that you want to?
Yeah, I think in terms of effect, that's something to really consider as well. Bowel cancer screening, we want the participation rate to go up. Right now, it's about 2 in every 5 people doing the test, and that's not enough. But even at that rate of participation, we're anticipating we will save about 17,000 lives in New South Wales over 25 years. If we can get that participation rate up to 3 in 5 people, that will be about 25,000 people in 25 years. That's 1,000 people a year is a lot of people to not have to die from bowel cancer, or possibly not even get a diagnosis. We've reduced the mortality from bowel cancer about 30% over the last 20 years. That's a combination of better treatment, but also screening. You know, it's a big deal. It's such a simple test. Just do it every 2 years. The other thing you might want to talk to your doctor about is what we call the alternative access method. So this is kits that your doctor, if they're registered with the portal, within the screening register portal, the doctor can now give out screening kits directly.
Oh, okay. Perfect.
So if you haven't had a screening test, sorry?
So we don't need to wait for the mail if the doctor...
No, well, look, if you're going to turn 50, yeah, wait for the mail, absolutely. But for people who've never screened, or who might have some barriers there and really want to talk to the doctor about it before they do it, they can, and the doctor can do a few things. They can call the National Cancer Screening Register on their behalf and get them to send the kit. They can also give them a kit directly if the doctor is set up to do that, if they've done the training and everything. So something worth talking to a doctor about anyway. And the other thing, we really touched on, which is that we've got an age change coming. But I would just encourage you, as whoever it is that's watching this, think about how this affects people in your community, and have that conversation and encourage each other to be getting this test done.
Yeah, that's good. So last point, any other developments or advancements you foresee in this field of bowel screening?
Yeah, there are always a lot of technological developments. We're seeing a huge change for good in terms of personalized medicine. I touched on at the start this idea that what we know about cancer is ever growing, that what we think is one tumor is actually multiple types with different characteristics and responds to different treatment. That's one thing. Genomics is another big a big part of that. That and technology, that all plays a part in treatment and doing treatment more effectively. But the biggest message here is that we can't screen for every cancer, but we can screen for this one. The biggest message I want people to hear is that no improvement in treatment is as good as just not getting it in the first place, or picking it up early. A treatment improvement is great, but if you could avoid getting it in the first place, if somebody's picked up at the earliest stage, they may not even need treatment. It might be that their gastroenterologist, their doctor, does their colonoscopy, snips out the tumor while they're having the procedure done, and they wake up and they're told that we found something, but we think we got it all.
Perfect.
That's much better. So yes. Look after yourself first.
Yes, exactly. Definitely, we have to look after ourselves. And when my dad was going through this diagnosis the year before last, and all of this was happening, people didn't want to talk about it in my family because the C word was a taboo word. Difficult because there are other people in the family that have had similar kinds of cancer that my dad had, but nobody in the family spoke about it. Had they spoken about it, perhaps my dad would have known and done maybe some earlier tests. And similarly for generations like mine and future generations, that's what I'm here to say. Let's break this taboo. Yes, cancer exists, unfortunately, but we need to talk about it so that we can prevent it and we can then move forward.
I think you're right. And everybody's got a part to play in really increasing that awareness that silence is so dangerous.
Thank you, Chris, for joining on this episode of Dose of Inspirational Light. Really appreciate it.
Thanks, Shika.